welcome everybody. Can I have any apologies for the meeting today? Any apologies, please? Katie, have you got any sent in?
Yeah, we've got Councillor Chambers, Councillor Owen, Emma Daly-Moore, Simon Vickers, and that's it. Thank you.
Thanks very much, Katie. Declarations of interest, usual, as you know, folks, if there's any changes to your declaration of interest, could you let the board support unit know, Katie, and they'll update them. Are there any items on the agenda today that may prove a conflict of interest for anybody in taking part? No, can't see anybody there. Thank you very much. So we'll move on to the minutes of the meeting held on the 16th of April 2020. Oh, sorry, Tony.
Caroline, it's not an item on the agenda, but it's just we're having problems receiving papers ahead of this meeting. We only received via email the papers on Friday afternoon. Ted only received his papers by post at 9:30 yesterday evening. Terms of reference state that we're supposed to receive the papers 5 working days before the meeting. And I've got to say, it's a struggle for some of us to actually spend the time that we need on going through the papers. Now, this is compounded by the fact that we have to go into the trust board papers to find the performance report. And I've got to say, I struggle to find it in the 597 pages, I think it was, of it. So I think there needs to be a review of what's going on here, please, to actually, if we can, do something. And we actually, some of us fed this back about documentation within the mock CQC focus group we had the other week about this very issue. So I'd just like to raise that before we start.
Tony. Yeah, no, perfectly fair point to raise. Michelle.
Well, thanks for raising it here, sir. It's better to raise it here than in a mock CQC inspection, to be honest, but we'll pick that up later. Just to say the word, probably just a few hours late, to be honest, and I'll come on to the service pressures that we've got, because we have several people down at the moment from an executive point of view, Tony. The board papers are fairly self-explanatory. You should be able to bookmark them and just get straight to the performance number on the item. I appreciate this 569, but we've been through that quite a long time. And actually, one of the things that's come out of the mock inspection is that they've actually praised our papers. As those of you around the table will know, I personally do not like and do not support people getting copies of paper copies anymore, unless there is a physical problem in relationship to those. One, mainly because of the security and the safety of them. And we cannot be in control of the postal system, Tony. We know how that works. We try and post them on a Thursday, those people that get paper copies. This time it was a Friday, so apologies, it was a few hours late, but we're all under enormous pressure. We staff down in the VSU for sickness and maternity leave, and I've now got some directors down as well. So I'm going to come on to that in my reports. I think we just need to have a little bit of give. If there'd been a problem before, Tony, please contact me outside the meeting. We could have had a conversation. We have written a paper about governance of papers, because I don't personally, I professionally, I don't like people getting paper copies, because I don't think in this day and age we should be doing that. It's a security risk. That's why people have to sign for them. So if people aren't in, then they won't be delivered. Because we can't have them going to the wrong addresses, etc. But I can't apologise for the postal system. I will, but I can't, because if we posted them on time, the post's supposed to get there. You should have had them at least by Saturday, if not by Monday. So apologies that didn't get there till last night.
Okay.
And that's not being defensive, Tony, because I'm not a defensive person.
I know you're not, Michelle, but I appreciate that. Thank you.
Let's take some of that away. Just to say, Michelle and I don't necessarily always agree on the paper issue. Particularly when you've got lots of papers on screens. However, everybody is sent the electronic pack, which gives an opportunity for people to have a look through that and see what's coming up. And then if they have had a requested paper, then they can look at those as well. So they are there. I know the board pack is large, but again, as Michelle just said, you can go down the agenda and just click on the bit that you want to look at in terms of the performance report as well. And also just to say, the performance report for this meeting was done in the way it was because actually at the time when we changed it, governors said they wanted something shorter and more simpler but still covering the issues for them to have at this meeting. But let's take it away. And just to echo what Michelle said, we are down on staff in the board support unit at the moment. So please bear that in mind as well. But we will take that away, Tony. Thanks for raising it. Isabel, I think I saw your hand go up there.
Yeah, it was just about the board papers, really, just to say, if people don't know, if you click on my very modern PDF version, it's called contents, but sometimes it's called bookmarks, and you can get a menu down the side, and then you can just click on the performance and it takes you straight there. And then what I do is do print PDF, and I pull it out, and then I've got it as a separate PDF, and it's just there. But appreciate that it's you know, sometimes when it sends the link in an email, the link doesn't work, so we have to faff around a bit to find it, which is why.
Yeah.
And also, just for clarification, when we asked for the shorter, simpler report for governors, my understanding was that that was in addition to the graphs, not instead of.
Yes,
Just
and
to
that's
keep
why.
note that
Yeah.
it wasn't instead, it was in addition. Thanks.
And thank you for that, Isabel. Maybe we could just to be helpful to everyone, just put what you've just said in a short email for people who may not realise that that's a way to actually get to these documents in a more easy fashion. And you're right, it was an addition that we did for the board report, and therefore that's why they're for the Council of Governors report on performance, and that's why they're there in the board report for people to take out. Thank you for that, Michelle, and then I'm going to move on.
Yes, I don't labour the point. Just to I know that you didn't say this, Isabel, but just in case people are printing papers out when they're at home, please make sure you follow the security document that we send out in relationship to how to destroy and get rid of those papers, because technically they're all confidential as well. So I know that's not what you said because you mentioned the PDF, but if anybody does print anything out, can you just make sure that you refer to the right storage and disposal of confidential waste? Thank you.
Okay, thanks very much. If you go minutes of the meeting held on the 16th of April, first of all, are they any corrections from anybody for the minutes before we approve them for accuracy? Kath.
Morning, everybody. It was just one of the items in one of the minutes. I'd made reference to the sickness being reviewed by internal audit, and it said internal audit are reviewing the sickness, but they are going to be. So it was just a timing issue, really. It's not due till November.
Okay.
I'm on page 6 of the minutes.
Okay.
Just a minor point.
Oh, yes. Okay. So that's under performance. Is that under performance report you're referring to?
It is. It
yeah,
is.
So for the minute taker, that's minute 29/26, and it's the last paragraph to be updated. Thank you for that, Kath.
Thank you.
Isabel.
Yeah, in minute 28/26, it said that I'd attended a place workshop. It was a pace workshop. So there's an L that's crept in there. Thanks.
Okay. All right. So that's, yeah, thank you. So 28/26 minute, pace, not place. Both are very important, but it's pace on this occasion. Thank you very much for that. I can't see anybody else's hands up. Everybody happy to approve the minutes? Okay, thank you. Are there any matters arising from the minutes or the action log? I've got one query. Anybody else before I just... No? Okay. So on the action log, the spotlight on a service, I don't think, which was around the children's and Thrives, I don't think the wording is actually right there in terms of, or understanding of the meaning from what I remember in relation to what was suggested about governors work getting together with the team on this. The action seems to suggest that nothing's going to happen till 2027. My understanding from the briefing was about how the team, the operational team, can engage with sort of more voluntary groups in the community, and that governors might have some links to voluntary groups that might be helpful, particularly for working with children and their families whilst they're waiting for assessments, for example. So I think I know Lynn isn't with us today, but if on the operational side, we can just, and with the board support unit, can we just go away and tidy up that action, because I don't think the action as it's written reflects what was wanted, and certainly the updated thing doesn't reflect it at all. So if that's okay, is that all right? Can I, Paul?
Yeah, this is something that I can take away.
Thanks,
we can
Paul.
look at, we just need, if we can just clarify what the action is. I think
Yeah,
I
exactly.
think I've got it, so I might need to
Yeah,
have another word outside of here,
Yeah.
but I can take that
yeah.
away.
Happy to have a chat, Paul. I think it's just clarifying. I think something's got lost in translation somewhere along the way on that one. But thank you very much. Okay, so if there's no other, I'm just looking around. No, no other hands up. We can move on then. And I'm really delighted to have Matthew with us today, Matthew Hanley, and we're having a focus on North Yorkshire's community services as part of our spotlight on a service section today. So Matthew, over to you.
Thank you, Caroline. Good morning, everybody. Thank you for having me this morning. I've got a presentation which I will share now. There are some acronyms in the presentation I've learned from the last Council of Governors. So I will say what the acronyms are, and then when I circulate the presentation, I'll make sure that the acronyms are changed to what they represent in full.
Thank you, Matthew.
Can you see my screen?
Yeah. Yeah.
Fabulous. So good morning. My name is Matthew. As we've established, I'm the General Manager for Community and Primary Care at Humber. I did attend the Council of Governors meeting in November 25. So what I wanted to cover today is just about how we've moved since that last presentation. So this is about from vision to assurance. So what has changed since November 2025? In November, Governors received an overview of the direction of travel for North Yorkshire Community Services, looking at integrated, proactive, neighbourhood-based care, supporting people and patients to remain well and receive care closer to home. This update today will focus on what has been delivered since then, what has measurably improved, where risks remain, how transformation is being governed, and how communities are supporting, how community services are supporting wider system transformation. Community services are moving from ambition into delivery with much stronger evidence across urgent response, neighbourhood health, intermediate care, quality workforce, digital and productivity. So sort of as an executive assurance summary, this strong assurance, which I will cover in the presentation around sort of our urgent crisis response service, the performance is nationally leading. It's ranked first nationally for its performance in terms of the National Oversight Framework. Adult community 52-week waits have been reduced to 0. We've achieved 91.8% RTT, which is referral to treatment, against a collective ICB target for providers for 70% for 26-27. We've had a 6.3 increase in patient-facing activity against the 25-26 baseline. We've completed a NICE endorsed evidence-based safer staffing tool for our district nursing teams. Humber are now contributing directly to a county-wide neighbourhood health planning through the North Yorkshire Health Collaborative Delivery Team, as well as a culture of continuous improvement, which is evidence across our teams, with staff-led innovation contributing to the trust being shortlisted for a HSG award in recognition of a community initiative. And we've also had the production of our first divisional annual PACE report for 25-26. Areas of continued focus in the presentation will focus on productivity, workforce sustainability, and workforce wellbeing and resilience. So in terms of the urgent crisis response service that I referenced just now, as I've said, we have been recognised in the North. It's one of the key metrics where we are one of 38 providers across England, which is an incredible achievement, and it's entirely reflective of the hard work that the staff undertake. The urgent crisis response, it supports admission avoidance, providing urgent care closer to home. There are, I think, 9 clinical standards, and it's mostly around falls prevention. So when sort of patients have fallen over, rather than dispatching YAS for an onward convey to the emergency department, our teams will go and respond within 2 hours and sort of try to prevent that admission. And this service is integral to our sort of frailty virtual ward and community admission avoidance service. In terms of our UCR moving forward, as an organisation, we always strive to be better, even though we are the best currently in terms of the NOF. But what we want to do is strengthen access to diagnostics, strengthen community prescribing pathways, and further develop the virtual ward capability and integration with our UCR service. So in the last presentation in November, I did update about our virtual ward service, which is proving really well, and we want to sort of better streamline the admission process if patients require sort of acute monitoring in the community. You'll see this throughout the presentation because we are asked by EMT so much, what is the so what? And the so what as part of this is the service is demonstrating that high quality urgent care can be delivered in the community while reducing pressure on acute services. Isabel, I noticed you put your hand up, but I'll keep questions till the end because Caroline likes to keep a strict time frame on the presentation. Moving on, neighbourhood health and integrated care. I feel as an organisation, Humber are helping shape the future of that neighbourhood model. What has changed since our last meeting? We have secured a position within the North Yorkshire Health Collaborative Delivery Team, supporting the Ambitious for Health programme and development of the North Yorkshire Neighbourhood Health Plan. Community services, intermediate care and local care partnerships have been identified as core building blocks of the neighbourhood health. Although we're waiting for sort of more national guidance to come, we're not waiting that before we actually progress with what's within our control. The programme brings together NHS trusts, the ICB, North Yorkshire Council, to sort of beginning to develop what we believe that neighbourhood model should be. And Humber's previous integrated neighbourhood team stocktake work means that the trust is contributing practical experience and intelligence into the county-wide design discussions. Again, so what? Humber, I believe, is helping shape the future of neighbourhood health across North Yorkshire rather than responding to decisions made elsewhere. Intermediate care transformation. So we're currently going through a place-based redesign. What has changed? There's a new integrated intermediate care model which has been agreed across North Yorkshire based on the Home First principles. The Home First principles is exactly what it says on the tin, home first for the patient, rather than thinking hospital, what can we do at home? The programme brings together health, social care and voluntary sector partners around a more consistent recovery and reablement model. Intermediate care therapy capacity has been expanded to support discharge and recovery close to home. And we have worked really hard with North Yorkshire Council to collaborate on a £330,000 proposal, which we have been successful for. The approval has been secured for the integrated workforce developments across the 2 organisations. And in terms of the so what, this is one of the largest community transformation programmes currently underway in North Yorkshire and will be a key enabler of future neighbourhood health models in the slide that I referred to previously. In terms of access and waiting list assurance, the progress. When I last came to Council of Governors in November, we reported, I think, 8 52-week breaches. There's a national mandate to have 0 52-week breaches. We have achieved that, we've sustained that, and we've driven the waiting list down even further. We have much stronger governance and oversight of the waiting list, and we continue to drive that position down to the 18-week constitutional target. The remaining challenge is that demand growth continues to outpace available capacity, and further improvement is required in the 18-week performance. We are 0.02% away from that national 92% standard, and we are above the ICB target, and I think the highest provider within the ICB with regards to community waiting lists. Although demand growth does outpace available capacity, it's what do we do as sort of managers and leaders to support frontline staff to be more productive, with technology. So what, since the last meeting, the focus has moved from reactive backlog management to proactive control and assurance. And you can see the graph at the bottom. The red line shows the ICB target in year for RTT. The green line shows the target for next year, and the blue line shows where Humber are as a provider in year. Digital transformation. So digital investment is supporting productivity, patient access and workforce efficiency. I'm really pleased to confirm that as a management team, we were greedy. There was an opportunity to put forward capital bids. We put the most forward. We got the most money back. So this year we're going to be receiving £621,000 worth of external capital investment to support more mobile working, virtual care, point of care technology and digital enablement. We've had increased adoption of Bridgid, which is basically sort of a patient record on mobile phones for staff so that they can access it. And as Michelle alluded to at the beginning of the meeting, around sort of security, of printing off paper, we've tried to eliminate that as much as possible with the use of Bridgid. And we've also improved communication with AccuRx, which is a text-based messaging system with patients, which ultimately reduces the administrative burden and has contributed to a 37% reduction in postage costs. Mobile technology now enables community teams to access records, document care in real time, and reduce duplication, helping release more time for direct patient care, which we will see further in the presentation. We've had new innovations, including the Lexicom AI scribe pilot. This is being tested to reduce documentation burden and improve clinician productivity. Digital developments are supporting wider transformation across our community services within urgent crisis response, virtual ward, intermediate care and neighbourhood health. Why this matters. Digital transformation is no longer about implementing systems. It's being used to improve patient access, release clinical time and support workforce sustainability, enabling more care to be delivered closer to home. In terms of quality improvement and the patient voice, as a division, we've had 476 improvement ideas, reflecting a strong culture of staff-led innovation and continuous improvement. We've had 188 improvement and development opportunities delivered, supporting staff capability and embedding improvement methodology across teams. We've had patient and carer involvement, and it continues to grow, ensuring improvement priorities are shaped through co-production and lived experience. And we, as I referenced at the beginning, we've released our first divisional PACE report, which sort of reflects all of that co-production work and the quality initiatives. And I'm more than happy to share that following the meeting if you would like to look at more of the detail. In addition to this, the Trust has been shortlisted for a HSJ award for the Risk of Bleeding Care Box initiative, co-designed by the palliative care team and community nursing teams, with patients and families to provide practical support, guidance and reassurance for people receiving end-of-life care at home. This initiative came as a result of a complaint raised by a patient, and as an organisation, I'd like to think that we're not defensive. We used it as an opportunity to work with the patient and their families and come up with this initiative, and as a result we've been nominated for, well, we've been shortlisted for a HSJ. The practical support, guidance, the project addresses health inequalities by providing sort of accessible equipment and information to support families managing palliative emergencies within the community. Why this matters, the so what. A culture of continuous improvement is embedded across the division, with staff, patients and partners shaping service innovation to ultimately improve patient experience and translating sort of those QI ideas into tangible improvements for the patients that we serve. Here is a small visual overview of our annual PACE report, which again, I said that I would be happy to share, and it covers all of the QI initiatives that we've covered in the last financial year, as well as the co-production that we have done with patients. So just in terms of conclusion and next steps, we've moved from sort of that vision in November to actually delivering more and providing assurance here today for Council of Governors. So again, just to summarise, since November, we are nationally leading urgent community response, as shown by the NUF. We've reduced 52-week waits. We've got strong progress in neighbourhood health and integrated care, with Humber contributing directly to the North Yorkshire Health Collaborative. We're going to be rolling out a new integrated intermediate care model across North Yorkshire. We're really starting to see sort of the tangible benefits from the digital transformation, all from a patient, staff and service perspective. We've got a strong culture of quality improvement, innovation and co-production, including the HSJ shortlisted community initiative that I referred to. And we also have an improved access, quality, productivity and patient-facing position. So in terms of next steps, we're going to continue on that agenda with neighbourhood health and wait for the national guidance to come out. But in the meantime, we will continue to develop the work that we can. We're going to embed the new intermediate care model and maximise the benefits from the home first approach. We're going to further expand the digital innovation to release clinical time and improve patient access, as evidenced by sort of the increase in patient-facing contacts, which I mentioned earlier on the first slide, I think, which was circa 6%. We're going to strengthen workforce sustainability through recruitment, retention and workforce modernisation, which we will be doing through the safer staffing tool that we've used. And we're going to continue to improve productivity and lastly build on our culture of co-production, ensuring patient and carer voices shape future service development. Thank you.
Thanks very much, Matthew. They're really interesting slides and well laid out. I look forward to having a look at them in more detail. We'll send all the slides, obviously, as usual, to everybody. I actually saw one of the bleed boxes the other week and met some of the staff who talked me through it, along with some visitors we had to the trust. And it's really a good example of working in collaboration with families at a time of life for their loved ones, which is really difficult. And supporting them to do so. So thank you for that. So let's go to questions then. Isabel, have you put your question in the chat box? Do you want to kick off?
Yes, thank you. Thanks, Matthew. It was a really interesting presentation and good to hear all the stuff that's going on and all the progress that's being made. My question was about the urgent crisis response pathway, and what are the numbers of patients that you see coming through that service?
See, it's around 160 patients per month.
Right, thank you.
Okay, short and sweet.
Thank you.
Tony.
Sorry, I feel like I didn't give enough detail there in terms of your answer.
No, that's fine. It was just because you had the
patients,
percentages. I was just thinking it was a percentage of what sort of number. It just helps to get the picture.
That's
That's fine. All I needed to know. Thank you.
Brilliant. Tony.
Thank you, Matthew. Thank you for that. I thought that was really helpful, really informative. I've two questions really. One is about the virtual ward. I see from the latest performance report that it's at 92% capacity. Now it almost feels counterintuitive asking about capacity for a virtual ward. What happens when you get up to capacity? Is there a waiting list for patients wanting to access the virtual ward, or how does that work? Please. Where's it gone?
Matthew? Hang on, let's give there. I think he's trying to come back in. I can see. All right. He's at the bottom there.
Oh, I'm back. I'm really sorry. The last bit that I got was 160 patients for UCI.
Just repeat it. Yeah, just repeat it, Tony. I don't know what happened there, Matthew. I didn't basically exclude you. I promise. Tony.
Matthew, thanks for the presentation. That was really helpful. Two questions. One is about the virtual ward. I see it's at 92% capacity, the last performance figures. What happens when it's up to capacity? Is there a waiting list, or how does it work, please, for patients wanting to access the service?
Well, I think it's the same with sort of any community bed-based ward, you know, when it's reached capacity, sometimes there is a waiting list, or we will find alternative means for the patient.
Right.
However, what we've seen more so in the past 12 months, especially when there are emerging system pressures, is that we are able to flex the capacity slightly. The restrictions in the capacity is dependent, you know, on staff travel, because
Yeah.
we cover such a vast rural area. If staff members are having to travel sort of all the way to Whitby, but then need to go to Scarborough and then Pocklington, you know, to visit a patient, that can impact on the level of sort of face-to-face activity we can provide. However, what we do is we do a heat map, sort of postcode analysis to look where patients are based, how many we've got, and if we can, we are able to flex the capacity. And we did see that some point earlier this year. I think we increased the capacity to 28 beds. But if we are fully occupied and there isn't available resource, then we'll sort of support with alternative methods, whether that be sort of district nursing, look at our physical, you know, bed-based community inpatient units.
Okay, thank you. My second question is about digital transformation. What about people, and tend to be sort of older people, who don't have access or don't know how to use, you know, use a booking system, check on, you know, make an appointment, so etc. You know, is there a concern that they're going to be left behind in this?
I completely understand what you're describing, Tony, because but my grandma is often calling me, you know, for me to help her with her own health records. But what I found is that to avoid digital exclusion, where we've got the digital inclusion of patients, that sort of releases more capacity for that sort of face-to-face effort with patients. So if a patient can't go onto a booking system, you know, to book their own appointment, actually it frees up the patients that are using that. It frees up more capacity on the telephone services, so patients are able to call.
Okay,
Carry on.
so
Oh, he's gone again, has he?
thank you.
I'm still here.
Oh yeah. Okay. Sorry.
Sorry.
There was sounded like a cat or a child crying in
Okay.
the background just then. Carry on. Sorry.
Okay, thank you for that. Thank you.
Okay. So what you're saying there is, because more people are using digital, it actually leaves time for staff, for those who can't, with those people. It just creates that other
Yes.
opportunity. Great. Okay. I will come to my NED colleagues, and I don't know, Paul, whether you just were adding something, but can I just ask, are there any other governors who would like to ask a question to Matthew about anything? Tim, I'm going to take governors first, if that's okay. Tim.
Thanks. It's just my ignorance. The map that you showed was of the whole of North Yorkshire. You've talked about North Yorkshire, but in fact our boundaries obviously are far more limited than that. The services that we're providing, I take it, are just simply within our boundary. You know, are we crossing boundaries to assist in any other part of any collaborative, or what?
So when I reference North Yorkshire, I mean Scarborough, Rydale, Whitby and Pocklington.
Right, you do, yes. So we stay within those boundaries. Right, thanks a lot.
Thanks for clarifying that, Matthew. And I'll take Marilyn as well.
In my experience of digital being helpful or helped the system to increase is not real. And there are a lot of people out there, not just older people, but people maybe who are housebound and so on, who really do need help with all this digital stuff, and it's scary. I was only speaking to a lady yesterday, and she said it's had a lot of friends who are finding it very, very difficult to cope with NHS stuff at the minute, particularly digital. So I think on the ground, you know, you might be saying it's actually letting other services, or we can have face-to-face appointments and so on, because that is digital is making up for that. It's not. It's an illusion. It absolutely is. And yeah, I just want you to know that, because I mean, I'm trying to start up a group in Market Wheaton for older people that we can help with that. But I don't want you to be under the illusion that the digital thing is going away, because it is not. Absolutely not.
Matthew, do you have a I don't know, some sort of panel or focus group of, you know, people in the community who are, you know, who are interested, but also are, you know, who may have had difficulties themselves, so we can almost, you know, have another sort of set of eyes and voices on just how this is working, so we don't get into a bit of a groupthink?
Yeah, I believe we do. I'll pick it up with Phil, who is our peers
Yeah.
coordinator. But I just wanted to come back to Marilyn just to say that I'm not,
Yeah.
I wouldn't like to think that I'm under any illusion that sort of digital initiatives are fixing the world. You know, it will take time, but what I'm looking at in terms of the success is the patient engagement, where we've got AccuRx. It's a two-way text messaging service. We've got the patient engagement where they are texting. You know, we've got patients opting in for digital letters. The digital initiatives are not an opt-out, and it's not mandated or enforced on patients. It's more so opt-in, and those opt-in rates sort of reflect the engagement and the success of the digital work. But I understand there are cohorts, you know, where patients will struggle, and absolutely we will support them through that, but it's not an opt-out service, it's opt-in.
I work with Phil, Matthew, so I know what happens, and Phil knows what happens as well. So if you want to have a conversation with him about digital inclusion at the lowest level possible, I think you should do that.
Okay, we'll take that away. Yeah, Matthew. Okay, I've got Ted, and then I'll go to the Neds. Right, Ted.
Yeah, good morning, Matthew. Thank you for that presentation. An impressive list of the changes you've made in the last 2 years, 1 year, 18 months, since 2025. Anyway, 2 questions. The first one of the changes you didn't mention was the reassignment of primary care practices. Given as a learning organization, what would you say was the lessons that you can learn from the implementation of that project? And secondly, is there any plans to monitor the performance after the change?
So I think when services are invited to present at Council of Governors to focus on a particular service, it's not, I don't think it's done to exclude other services. So I didn't include primary care within the presentation because I was asked to present on.
That's all right, Matthew. That's okay.
In progress.
So in terms of the lessons learned, we're working through. I think there was a lessons learned that went to a board report that went to EMT. Obviously, we're coming to the conclusion of that primary care transfer work, and we'll be able to sort of bring in those lessons learned into the services that we're currently operating within the trust.
And I don't think the plans for monitoring performance,
managing performance of what? Sorry,
of the changes as part of the learning process.
Are you sorry?
Sorry,
I'm getting.
Sorry, should I come in there?
So I was just going to say, I'm getting a bit confused, Ted. I mean, if the practices are moving obviously to new providers, what I can say is for example, if there are any issues around any complaints that have been raised within our time, then they will all be dealt with until obviously that, you know, to see the end, because they started on our watch to resolve. If you're saying about learning from the transfer of those services, of course, there's learning in all of that as well, that we would discuss within the board. I'm not sure what else I can think of where you're going there.
Okay.
Can you be a bit more specific, Ted?
Let me try and explain. As a learning organization, you learn from what you've done in the past.
Yeah.
What you've done in the past is changed the management style in the 3 practices. That has an outcome. When you were doing the changes, you had an expectation of that outcome. are you going to measure your expectation against actuality as part of the learning?
Okay, Michelle?
So
Michelle,
I'll put
you're-
myself out. No, but I know I'm off now. There's two questions there, Tim. One, yes, we'll do a full debrief, absolutely, and we will look at the beginning, the middle, and end, and how that happened. But in the longer term, in relationship to performance, no, we won't be monitoring that. That'll be up for the integrated care board and the GP contractual arrangements, to be honest. But we will look at our bit in relationship to from a transfer point of view. Yes, we've made some assumptions in the project plan, which we will test. And we will look at when we do the full evaluation and the briefing that will come probably in a few months' time when we've had a chance to obviously settle all 3 practices down. But once they transfer, as Caroline said, they're no longer our responsibility, so we won't be performance managing them at all. The ICB will, and we can always ask the ICB what the state of play is, but we won't be doing that directly. Neither will we have the authority to do it.
Yeah, I understand you won't have any further responsibility for the new practices. Quite right, because they're under new management. But you did have an expectation of how the project would go, and that expectation can learn about whether your expectations were good or not.
Yeah, there is a project initiation document that sets out the actual transfer agreement and what we're hoping to get. So that's what we'll test at the end. Yeah.
Okay. Thank you, Ted. Okay, Steph, then Andy, and then Kath. Steph.
Thanks, Caroline. I want to return to community services in North Yorkshire, if that's okay.
Yeah.
And thanks for your presentation, Matthew. Good to see you. And really, really great work. Firstly, a comment, and it's just on the digital transformation. My observation is that I'm really impressed with how our staff take a holistic approach to assessment of patients, looking at all aspects of lifestyle and health, and putting a real upfront investment in that analysis before looking at care plans and treatment plans with people and assessing how patients are progressing. That's a huge investment in time and energy and working with partners as well. And I think the exciting thing about the digital investment is how then we reap the benefits of that work later down the line and how we're better able to manage that in turn with the patient as well. So it's not so much the interface with the individual patient, but how the staff can work with the patient with that information from all those various sources to do that holistic approach. And I think that for me, that feels like the really exciting thing. And I know there's a great deal of buy-in from the staff for that kind of approach as well, that holistic approach, which does bring benefits and totally recognise what's been said about the potential for digital exclusion of patients. But I think there are benefits on the flip side in terms of patient care and how we manage patients going forward. The question I have is a different issue, and it's around that you sort of developing your so what. So we talked about the number of patients we're dealing with, the throughput of patients through the service, but I'm interested in the impact on our acute partners and how many people are we preventing from having to attend acute services or be inpatient in acute services, and how are we preventing that happening and enabling people to stay at home? And do we have some figures around that would help us to understand that kind of impact, which is hugely important for patients?
Matthew?
Thank you, Stephanie. I don't know.
Steph.
Yeah, Steph. Thank you, Steph. Yes, we absolutely look at the impact of what our work will do on secondary care, and as part of our sort of winter planning submission, what we do is we look at the baseline of the last year, and we look, so say for example, I think when Isabel asked how many patients do we see sort of per month, 160. what we do is we look at the conversion rates of those patients per month, assuming that all of them would be admitted to secondary care. And then we look at the outcome. So if the outcome for the patient is to remain in their home, or it's for them to step up, then we use that as a percentage and apply that to the overall number of contacts per month and provide that to York and Scarborough for inclusion in their ED performance, to say, we believe through our service, we are going to prevent this many attendances, York and Scarborough ED. So we have that data. I'm more than happy to share it. And it's a very sort of high conversion rate of patients for them to remain within their home.
Thank you. That's helpful. I'd like to see those figures. That would be really helpful. Thank you.
Yeah, if you could, that'd be lovely, and we'll share those with everybody, board and governors. Kath, oh sorry, Andy.
Thanks, Caroline. Morning, everybody. Morning, Matthew. It's great to meet you. As you know, I'm a new NED. I'm also new to the NHS. And I wanted to ask a question, which I think probably comes under the heading of a universal problem for the NHS. You mentioned in your presentation that demand is outstripping capacity. What are the implications of that? Because if that continues, it's bound to create sort of all sorts of knock-on issues. So would you, if you could just maybe comment on what the potential implications of that over the sort of short to medium term?
Of course. Thank you, Andy. Nice to meet you. Thank you for your question. So it's a risk more than an issue currently, because what I went through in the presentation was how actually the different ways that we are working, using sort of skill mix. Not everybody needs to see a senior clinician, but also using the digital initiatives to be more productive from a staff perspective or from a patient perspective. It actually increases the throughput. And I think I referenced that our number of contacts using the same level of workforce was up by 6 to 7% against the previous year. So in terms of the short to medium term, I'm confident as sort of general manager that we are being as efficient as possible to increase capacity to sort of keep up with the increasing demand that is coming through, especially more complex patients. And then in the longer term, I would hope that through the sort of partnership working through the neighbourhood health work, where there's more MDT working, we're working together, there's less sort of review of patients in silo, we become more productive across the system and not just as a provider. That would hopefully support more of the increased demand. But I can't comment on sort of government funding, unfortunately.
No, of course. Thanks, Matthew. I think that, I mean, it's reassuring to hear you say that, actually. I'd be interested to see how that kind of continues to play out, and possibly over the course of, I don't know, the next 2 or 3 years, I'd be interested to see that, how that kind of comes together in data and so forth. So, but thank you.
I'm sure we'll come back to it, Andy. In different guises across the trust. Thanks for your question. Thanks for the answer, Matthew. Kath, and then lastly I'll come to Tim, and then we'll move on. Kath.
Okay, thank you very much, Chair. Hi, Matthew. Nice to see you again. It's been a long time, hasn't it? Anyway, my question is connected really to Andrew's, because I loved the slide you put up around the waiting list management, and then you went on to talk about the digital, and I kind of see the two as very connected. So introducing that two-way text messaging when you're talking about the Bridget and the Accurix programs, that has been proven elsewhere to drastically reduce your DNA rate, thereby improving your efficiency and your ability to contact, and therefore reducing your waiting list. So it was similar to Andy around, have we seen any improvements in the DNA rates, etc., which is it's kind of that efficiency and productivity agenda, which then can impact on those other things which you put on the screen.
Yes. Hi, Kath, nice to see you again. So yeah, we are seeing the measurable impact of that through there's a big focus as part of the North on productivity and the National Cost Collection Index, and what we are seeing is an improvement for our community services in terms of that throughput. So what will contribute to that is if Obviously, we're being more efficient with our resources. We're able to see more patients, more direct clinical contact. But alternatively, if we're mitigating against reduced DNAs, then that increases the throughput of the capacity, that we've already got. So we are definitely seeing the outputs of that in the National Cost Collection Index.
Yeah, it's really good to know. Thanks, Matthew.
Thanks, Kath. Finally, Tim.
Just picking up on what Steph's point was, it occurs to me that there must be a considerable financial benefit to Scarborough and York Trust. Are we able to quantify that financially? And if so, do we get any financial benefit from them, any share of that at all? And is it something that could be considered? Because it just seems that we're providing, we're paying for a service from which they're benefiting, and we may be getting nothing from it.
I mean, I would say that's a finance question for Pete, but I do think.
Well, I know Pete's on this meeting as well. So
yeah, I would say that in terms of the maturity, from my experience within the ICB, it's you don't give something to receive something, and I understand the point around the financial savings, but as we become more integrated and working as an ICB system, the priority is that the ICB sort of reaches a net position in terms of its finances. So if we as a provider are commissioned to support York and Scarborough to improve their performance and reduce their costs, that would be reflected at an ICB level. In terms of sort of billing them for that, I don't think that's in the public. Pete, I don't know if you wanted to come in.
If I can come in very, very quickly, Caroline, I think what Matthew's described is the ICB, and we have to remember we're in a really the worst challenge system in the country, and in the ideal world, the ICB would be pump priming community services to reduce the demand in the acute sector, and then that would play out in the future in terms of they'd be commissioning us to do more, which would reduce the what used the word version, the demand on the acute sector. That's how it would work. But unfortunately, given the financial constraints across the system, we're not seeing that left shift funding that was made available in allocations, just because the ICB are unable to afford it at the moment. So that's how it would work in practice, Tim.
Right. Okay.
So basically, strategic commissioning, Pete, if we had the bandwidth to do that, would completely logic tells you would have more of what Matthew's been talking about.
Yeah, absolutely. And if you had a 3-year plan, that was a 3-year plan, Caroline, and I've said this on national forums, you'd run an investment in year 1 that pays back in year 2 and 3, but we still operate on annual control totals.
Yeah. Paul, did you want to add something to this question and answer for Tim?
Yeah, I was just going to say, I think Pete's covered it really, but I'm just going to add is that from a strategic commissioning point of view and working obviously with the ICB and the new ICB priorities, one of the work streams is absolutely around that left shift into the community, but also is that how does the money follow? And that has been an age-old problem that we've been involved with for quite a long time. But going forward, that is absolutely part of that work stream around looking at how we can bring more things out into the community and how that money is pulled out following it. But that's not something that's going to happen overnight, as Pete's just said.
Thanks.
Thanks, Tim, for that question. Thanks very much, everybody, for your questions and comments. Really helpful. Matthew, thank you very much for that presentation. I thought that, as I say, I think that presentation was really good. I'd like to see more of that coming through, that sort of what we're doing, what's changed, so what. Really good approach. Thank you. And it's a really important point to just reflect on how important community services are to the all the services that we provide in different ways across the areas that we cover, and all the work you are doing in your team. Should there come an opportunity for better strategic commissioning, we will have the evidence to stand up and show what can be achieved. So it's not in vain. It's all really, really important. And please reflect that back to your team and colleagues as well. We appreciate it. Thanks very much. Can we show our appreciation for Matthew, his presentation and dealing with all those questions? Thanks very much. Thanks, Matthew.
Thank you for your time. Bye now.
Cheers.
Thank you, very good.
Okay, we'll go on to my chair's report. Just a couple of things I just want to flag. First of all, It's really sad, but Simon Mills died recently. I put it in my report. Simon was only quite recently became a staff governor, but he's worked in health for a very long time. And when he first came on as a staff governor, you know, I talked about his work at Humber and how much he enjoyed it. And it's really sad news to hear of his passing. A card was sent to his family with our sympathies and thoughts to them. Secondly, I just wanted to flag that we have gone through the appraisal round that covers the year 25-26 for both all the non-executive directors, apart from Carrie and Andy, who were too new really to be able to do that, and also independently by Steph as a senior independent director with, for myself, Marilyn Foster as chair of the ATC Appointments, Terms and Conditions Committee, also partakes in those appraisals. And yeah, it was very good both to hear from everybody, but also to explore their objectives from last year and looking ahead. And a full report went to the Appointments, Terms and Conditions Committee yesterday. So I just wanted to flag that with you. And secondly, also again, another update report went to the Appointments, Terms and Conditions Committee yesterday. Council of Governors approved, I think it might have been at the January meeting, that we should look to recruit another associate non-executive director. We had quite a lot of recruitment activity in the last year, and as a result, we had obviously Kath come on board as audit chair, and Carrie and Andy followed when we completed that in the spring of this year. So we did agree that we should follow this up after that. An update report on recruitment went to the ATC yesterday, in which the committee governors, governor-led committee, were happy to proceed with initiating the recruitment round for an associate non-executive director. I just want to remind governors as well of this opportunity is, you know, when we looked at this, we did agreed that what we wanted to think about is how we could encourage a better network across our health system area with other health providers who also may have associate NEDs, to see what we could do to enable a network to be run, not by Humber, but we would look to the ICB and the region on this, to, if you like, support development and also encourage talent and exchanges across different health providers amongst this group of people. And in doing so, we think it'd be really good for those associate non-executive directors, but also, and if there is opportunities come up and vacancies, they can look at Humber, but they could look wider, and so could those other associate NEDs from elsewhere. So we see that as a positive going forward. Those were just the three things that I just wanted to flag. I'm happy to take any questions on that or the report. Any questions? No? Great. Fine. I think just check the right. Brilliant. Great. Thank you very much. We'll move on to the Chief Exec's report.
Thanks, Caroline. Thanks, everybody. Good morning, everybody, again. Great presentation from Matthew. I agree. Some really great questions, so thanks for that. I will take it as read that you've obviously read my report, but I will pick out a few things and add a couple of things that just didn't quite make it in time, because we are working at such a phenomenally fast rate. We normally work at a very challenging fast rate, but it just seems to be getting even more, not the usual chaotic, but even more difficult and challenging with things that are happening around us. It's good to see the visibility of the execs that is still taking place, as I say, even though we have got some challenges within the systems and the team. Gold accreditation is we're still waiting to see if Hull have been redesignated gold, but it's great to see that East Riding maintain that. That's really important for that preventative first steps in life as well. And we are, just to remind you, that we are one of the few systems, and it is a joint system with the local authority, and I work really closely with the councillors there on it. Is one of the only systems in the country that is gold, and certainly maintaining that. With lots of appointments happening, which are in the paper, I won't go through. You can see those. Still got a new Secretary of State. Who knows what may happen in the next couple of weeks, but we have Scott James Murray, which we've met a couple of times, and he is really sort of saying, well, steady state at the moment. But I think given Andy Burnham's speech around the importance of the NHS, but not labouring the fact it's broken too much. It was quite positive. It's been received quite positively. So we'll keep you informed as that obviously it just develops. The important things on mental health are the mental health strategy, which I put in there, which is around bringing in the work that Millban's been doing on not in employment or education. I think that's going to be an underpinning architecture, which is quite interesting. The preventative model and a move to that preventative type approach rather than the high-end mental health. And it's going to be for 10 years. And I'm working with Region to pull together a bit of a working group to look at that, and also to look at the response to the five plan. And the 5 plan is to set ourselves really challenging targets of the sector, which are around out-of-area placement, neurodiversity in children and young people, and ED weights. And we've set ourselves as a whole system across England some challenging weights on those, which I think is quite positive. Modern standard framework, service framework for mental health is still awaited. There's been a few come out for the acute sector for various conditions. Diabetic, there was the last one last week, still waiting for the mental health one. Neighbourhood structures are still developing within the ICB around 6 places, and we're still working with the ICB on those, and the Health and Wellbeing Board's being fairly central. But actual guidance from the central neighbourhoods, I'm not sure we'll see anything at all, because there's so many differing opinions for the right reasons. We've started our winter planning, as you would imagine, when it's boiling hot outside and we're all looking for fans and fluids. We always start our winter planning. We've initially tested some of those, and I thank the operational team on that. And we've got our flu plan in place, ready to go when we get the flu vaccinations. There is an update on communications in there, because I think some of the governors like that. That just gives you a bit of a breadth of knowledge. We're getting quite a lot of positive news stories in, which is really great. And there's about the health stars. Just to remind all the governors, if you want to come and help support me, my challenge is next Wednesday or next Thursday. I think I've got the 22nd. I've got no idea what I'm doing, but it's a series of challenges set by staff. And I have to do a forfeit if I don't do it. So I'm expecting them to be very difficult. Alongside, I'm celebrity to get me out of here. I have reminded them I'm a vegetarian, and I get a badge if I get it done, and I get some extra money for Health Stars. I think at the moment I'm already raised nearly £1,000. So thank you for that, and that goes into the Health Stars Fund. Probably the only chief executive in the country that's daft enough to do that, but it's a way for me just saying thank you to staff. 2 important things I mentioned: out-of-area placement. We're looking at due diligence at the moment on our out-of-area placement, and looking at how we can look at managing that on behalf of the ICB. So that's really positive. Our conversations are beginning to come to fruition, which is, I think, really good for the communities. And the same for ADHD waiting list, but particularly the ongoing capacity issue around ADHD and right to choose. So again, watch your space on that. Lots of work going on, but it's really positive. The ICB have announced a community services review for all their community services. I can't give any more details than that because we're still awaiting it at the moment, but it will be a fundamental root and branch review of community services across the patch. I think, as somebody alluded to earlier on, we are working on support in one of the most distressed systems in the country. So that isn't without challenges, and their financial position continues to deteriorate. But we are working well within that, and our performance is still excellent, and we've still got high capacity capability rating. I do want to mention a couple of the pressures. We have got some absences in the business, in the BSU, so please bear with us on that for various reasons. And our Chief Operating Officer, Lynn, is going to take a period of health. So we are at the moment looking at how we can facilitate cover on that. And I thank Paul and Claire, and specifically Paul at the moment. Claire was off last week, for the sterling job that they're doing in relationship to covering that at the moment, but we will have some more longer term plans in place when they're fully ironed out. It would be remiss of me not to mention, but Paul is here. I'm going to say, Peter Matthew's gone. I want to particularly thank Matthew and Paul and the team for their sterling efforts last week with the Moulton fire, because that was an absolutely catastrophic critical incident that could have been absolutely catastrophic. And people know me, I don't use that word very often. And the building that actually ignited the clock fire was just next to our Fitzwilliam ward, literally within touching distance. So if it had been windy, like it was the day before, the whole lot would have gone up. The fire service did a remarkable job to maintain and keep it contained within that building. That building wasn't so much of a problem because there was 2 patients in there, both of them leaving were there, and the staff evacuated quite quickly. Ours had 14 patients in there, very frail, very elderly. And the staff did a fantastic job to decant them, evacuate them, follow the procedures into the school, and actually visited the staff and the patients, and they were all great, felt great, but really the patients could not commend the staff enough for how calm they were while it was happening. And they said, look, we were really anxious, we were scared, but the staff were just calm, in control, so that made us feel better. And I think that just sums up the work that took place. But it was a real partnership and a community effort, because the police ferried our community staff because they couldn't get the cars to the visits in the afternoon. So there were some of our outpatient clinics cancelled in the afternoon in UEC, etc., for a few days. They started to come back. We have got some fire damage on Fitzwilliam ward, and also some issues around evacuation. Fitzwilliam evacuation moves towards the back. But we have got the patients back from Bridlington, which is where they were evacuated to altogether, which is great. So everything is fine, the patients are fine, everything's back, but we are operating on a smaller unit capacity at the moment because of the evacuation issue. It's fine, by the way, evacuation. It's just we had a full ward, we would have a bit of an issue at the back. Paul, have I summed everything up there, or is there anything I've missed?
No, thank you, Michelle. I think you're quite right. Our staff are just phenomenal. The way that they manage the whole process, and that ensuring, and I think everybody involved, just making sure that our priorities are patients, to keep them safe and well, and then obviously it's about our staff as well to keep those safe and well. And I think everybody has pulled together tremendously to make sure that remains our focus throughout of this. And yes, as you say, everybody is back at Moulton. I was up at Moulton when they arrived back the other day, and you could just see the relief on people's faces that things were starting to get a little bit back to normal. We will be having a full debrief, and we'll be having various reviews and system reviews, because out of all of these instances, there's always things that we can learn. But at this moment in time, I think everybody involved can be pretty relieved and happy that everything was done as we should have done it, and staff and patients are well.
And there was no casualties at all, so it was absolutely sterling work.
We were very lucky.
Yeah, well, no, I think it was work by the staff.
Yes,
it was excellent handling by the staff, and it was excellent handling by the fire service as well. Yeah. But it could have been catastrophic if it had been windy. The whole lot would have gone up. And obviously, we're doing some psychological support in there as well, because obviously, as they were evacuating, the oxygen cylinders were exploding and various other things as well. So it was a particularly difficult time, but we have thanked the staff. We'll continue to do that. I did go up and visit as well, while they were decanted at Bridlington on purpose. So but as I say, we've de-escalated it now from critical incident into business continuity, and it will stay there until we can start to reopen the whole of the unit at the moment. Tony.
Oh, sorry, can I just check something? Have you finished the chief exec's report?
Yeah,
so that
I didn't know if Tony wanted to come in on the Moulton fire.
No, that's fine. But if you've finished, I'll open up for questions then, Michelle. So that's great. Okay, Tony.
Michelle, I dropped you a note, I think last week. I was actually working on Moulton ward until last year as a bank nurse, so it felt very real to me. And for those of the governors, knowing how close that unit was to Fitzwilliam ward, it was incredibly close. So I think it's worth just putting on file and documenting the thanks of all the governors for the excellent work the all staff involved did in inventing what could have been something pretty terrible, and it wasn't. So thank you.
Thank you. We'll make sure that's passed on to the lead. I met Phil, I think it is, last week as well. I see the senior matron on the ward there, or manager on the ward there. He was at one of our marketplace events for visitors, and I was able to thank him directly and pass that back to staff too. But thanks, Tony. Ted.
Yes, I just wanted to ask, is the success, if you can call it success, of dealing with the fire, was that due to having a pre-plan that you practiced before? And does every place has a pre-plan that they practiced before? So is there some learnings that can be transferred?
That's a good question, Ted. I mean, yes, it was a success, to be honest. I didn't use that word correctly, to be honest. There is always learning that we can do, and we will do that. I think probably very minimal will come out because it was such a successful evacuation. Every ward, every area has its own business continuity under the emergency planning processes. So depending on what sort of unit it is, they will all have a plan, a fire plan, whether it's a stage, because obviously the evacuation is the last resort, not the first resort. It's usually you go from zone to different zones. So each of our areas is categorised in different sections and different zones. So depending on what sort of warning and alarm it is, depends on what happens. But each of those plans are tested on a regular basis. People have fire mandated training, as we all have to do anyway, including everybody around the table. But those plans are checked. We do usually, we don't do full-scale evacuations, like obviously the one we had to do at Malton because of the frailty of the patients. But what we do is mock evacuations, and a lot of the time desktop evacuations as well. We have got ideas on most of the areas around areas to decant out to, but that's usually the difficult problem, where you're going to decant the patients to on a more longer term basis. So each of those does have plans. Just our fire officer Paul Dent monitors them, and the fire service monitor our performance against those as well.
Sorry, did you say you involved the emergency services as well on the pre-plan?
The fire service monitor our fire regulations and our fire processes, but Paul Dent is our fire officer.
Okay, thank you. Thanks, Ted. Tim.
Thank you. Two comments. One is on the national sort of picture. Excuse me, got a cold. I'm just simply commenting that I do so object to the major structural changes. The idea that there's going to be a more centralised, ministerial, accountable NHS. It flies in the face of what the incoming Prime Minister is talking about devolving power out. And we're turning the clock right back to the NHS being based centrally and all decisions coming from there. So in future, I mean, minor matters, you may think, we're not going to be able to appoint our own chief executives or chairs or anything, but those are maybe some minor matters. It's generally the thrust of it, as just as a comment that I just feel very strongly about it. The other comment is about the flu plan. I think it was at the last council that I raised some queries about whether one could do anything about contracts, and I was told no, one can't. But I do want to congratulate the Trust on the considerable increase in the amount of the flu protection that has occurred as a result of the hard work that was done last winter in the planning. I suppose I'm disappointed that it's only 66%, but I see that was the second highest national uptake, which I just find appalling overall that it is as low as that, but there we are. But well done, and I think hopefully it'll be even higher this forthcoming winter. Thanks.
Thanks very much, Tim. Are there any other questions on the Chief Exec's report? I just wanted to flag, because I was flagged to me the other day. Do we know when on the Malton situation and just kind of a shout out as well for the school? You mentioned the school, Michelle, that were absolutely brilliant, provided refreshments and everything for all the people who were evacuated there, whilst other plans were being met as well. So that was great collaboration with the school playing a really important part as well. But do we know when the fire services will provide their official, if you like, report on what caused it? Do we have any idea when that might come through?
No, not yet. They were still investigating. Unless Paul's got an update for me today. He's going to say yes, aren't you, Paul? Because last time I spoke to the fire service, they didn't have an idea at the moment.
No, so through the Health Coordination Command meeting, which is run at kind of from a regional level and an ICB level, this is always on the agenda to find out any further information regarding the fire. The last meeting we had on that was on Monday, and as of Monday, there was still no update from the official cause of fire. So the Health Command, Health Coordination Group, it's an open log on their log, and it will be something that as soon as they do know, we will be getting the information. Obviously, TÜV are leading on this, as it was a TÜV building, and they will update as soon as we know.
Yeah, thanks very much for that, Paul. Appreciate it. Okay, thank you very much. I cannot see anybody else's hands up. Thanks, Michelle, for your report. We'll move on to item 8, which is compliance with the provider license, and Pete and Stella are leading on this.
Would you like me to introduce Pete?
Yeah, you introduce Stella and I'll just support as needed.
Okay, all right. So on an annual basis, we present to the board and the council of governors updates to how we're meeting the terms of our provider license. And the reasons that the board and the governors get this report is that they need to assure themselves that the trust does not breach the conditions within its license. So we collect a substantial amount of evidence which shows how we are and continuing to meet the terms of our license. So that's the purpose of the report. The report you've got in front of you, the changes made to it since last year when the Council of Governors and the board received it are highlighted in red or strike through. It is updated, every year, and it has a, EMT look at it as well. So the board has already received this report and didn't make any changes to the evidence within the document, and it's here for the governors to look at and ask about any of the evidence or highlight how any sort of changes that we might want to put in there.
Thank you very much, Stella. Are there any questions or comments for Stella or Pete? Tim.
I'm sorry, it's me again. I normally would have written to Stella on this because I've picked up one or two things in past years. G5, Stella, the bit in red says the 2024-25 annual head of internal audit opinion is expected to provide. Do you mean to 24-25? That is correct, is it? It's not 25-26?
It is 25-26, Tim. So well done. You've spotted something that quite a few of us have missed. So thank you for that.
Well, that's one thing. Maybe there are others actually, because this is for the year 25-26, isn't it?
Yes.
Report, right? Okay. So the front page refers to the board undertaking a review held on the 27th of May 26. And then the positive assurance to provide again on the front page key action says was last approved by the board in May 25. You haven't approved this then, or is it for us to approve first, or when's the board going to approve it?
So the board has approved it this year, so it approves it on an annual basis, Tim.
Right, well,
the governors aren't required to approve this. It's
right,
the board that approves this.
That's fine. It's just simply the wording there. Then it was approved by the board in 26. It's not 25, but it doesn't matter. That's not the important bit, is it? It's the bits in red. So we've dealt with G5. Can I just point out, although it isn't in red, IC1 refers to the lead provider as the Humber Coast and Vale geography. Do you still mean that, or should that be changed as well?
Are you able to answer that one, Pete?
I think, again, it should be Humber and North Yorkshire geography, shouldn't it? It was coterminous with the ICB footprint, so again, well spotted too.
Thank you. Oh dear. And were we placed in segment, when this is now COS 3, were we placed in segment 1 before April 26? Because this is referring to year 25-26. And you're saying the trust was submitted break-even fund. Oh, sorry, where are we? The trust was placed in the highest segment as part of the oversight framework. And I put there for 25-26, was it not, would it not be 26-27? Or was it before?
I can answer Tim. It was based on performance at the end of Q3 25-26.
Oh, right,
So
that's
assessing
fine,
our performance at that time. I
That's
think we were
fine.
notified first week in April, so we was able to incorporate it into the board
No, that's
paper.
fine. That's fine. Thank you. No more. Thank you.
Thanks
Hopefully
very
that was
much,
helpful.
Tim. Do you want a job as the proofreader, I think, basically, for some of these
Well,
things?
I do pick things
There's
up
a-
each year
there's a-
to
there's-
do with this.
No, it's fair enough. I mean, it is important, and especially just getting the dates right is really important as well on the documents. So I'm sure Stella and Pete and others who draft reports will note that as well. But thank you for those. Thank you. Thanks for sharing those. Any other questions from anyone? Tony?
This is obviously a very comprehensive document, which took a bit of trawling through. This might seem an odd question, but how would we know as governors if the trust had breached the license? You know, what's the reporting mechanism for this place?
It'd just be, if you were concerned about anything, you could see here what's in the license and the conditions
Right.
are. So each of those terms within the license are in this document here. And we're outlining how we continue to meet the terms of the license.
Right.
I suppose what Tony's asking, who marks the homework?
That's a
So-
good question, Caroline. It's just it's
Pete.
for anyone, I think, just thinking, well, has there been a problem? I'm not suggesting there has, by the way, but then you've got to go into this document and actually try and interpret what this means. It struck me as slightly odd, if I put it in those terms.
Pete.
Yeah.
I think, hopefully this didn't come across clumsy. I think as a board, it's our responsibility to ensure we comply with our licence and the decision making and the business we conduct. So we do that. It's always in the forefront of our mind. That's why we have policies, procedures, scheme
Sure.
of delegation, Tony.
Okay.
Previously, we had to make a formal annual declaration, and I remember it very well because I picked up the job card originally to provide a suite of evidence to comply, to demonstrate we comply with our provider license, which you would expect us to do from my previous statement. I do know in other organisations, they don't follow a process as comprehensive as this. And we
Right.
have shared it with other organisations. So I guess the short answer is, as a board, if we weren't complying with our licence, we aren't doing our job properly. It's our responsibility to ensure we do that. And that's what we do through all our board and governance structure.
Right. Thank you. That's helpful.
Kath?
I was just going to add on to what Pete said, really, because I also remember the days when we had to make an annual submission, etc. And I think it's really good practice that this trust has decided to keep that kind of format and process, even though it doesn't need to be submitted to regulators. But I guess from a NED perspective, what I was looking for was kind of that triangulation with other things we know from our regulators, which are obviously that independent assurance. So things like head of internal audit opinion, your feedback from your external auditors, any feedback from NHS England, and any feedback from the CQC. And obviously we're not hearing any negative noises from those at the minute, other than the CQC, which is outstanding, which governors know about. So I guess when from a NED perspective, that's the kind of thing we're looking for. And Pete was right when he said around the head of internal audit opinion of significant assurance, it's a good outcome for the trust. And obviously I'll talk a little bit more about that later when I do my chair's report. Thanks, Chair.
Thanks, Kath. Thanks, Tony, for the question. Okay, I can't see any other hands up, so therefore I think we can move to the non-executive director chairs of subcommittees report, and we're going to start with Keith.
Hi, good morning. So this report relates to a meeting which was on the 21st of April, which feels like quite a long time ago now. In fact, our next meeting is next week on Tuesday, so it's been almost 3 months. So I think some elements of this, I have to say, on reading, feel a little bit behind the time now, but flagging no real major issues of concern. Actually commissioned some work around agency plan and the focus and target from NHSE around reduction in agency use, both bank and agency use. So a request that we're looking at the July meeting next week around that. And continued work around efficiency and productivity. We've moved the finance committee into 3 sections. So the first section's around grip and control, middle section is around efficiency and productivity, and the third section is now around digital specifically. So it will become effectively the finance and digital committee, I guess, moving forward from July, to reflect the importance of digital to the organisation and our patient care moving forward. Caroline, I think I'll take it as read beyond that because it is quite dated. If there's any questions, I'm very happy to take them, but I'm not sure it's too relevant to be talking about some of the numbers in it because it was so long ago.
Okay, thanks very much, Keith. Any questions to Keith on this report? No? Thanks, Keith. Move on then to Carrie.
Morning, thank you, Caroline. So we met on the 6th of May. So again, it is quite a way back, and we have met once since then with a shorter committee, which was just to approve certain reports that needed to go through the committee first. Oh, I don't know whose that music is. No, it stopped. So the committee received strong assurance that the trust continues to perform well across workforce, across wellbeing, education, equality and financial performance. The workforce indicators remain positive with low vacancies, high training compliance, improved recruitment, reduced agency use and the year-end financial surplus. So that was all really positive. The 2025 staff survey showed high levels of staff engagement, inclusion and pride in working for the organisation, but we do need to do further work around the quality of the appraisals, around staff wellbeing and speaking up. Key programmes were discussed and are progressing well, and they include the Medical Workforce Plan, the Employment Rights Act readiness, Transforming People Services and the 2026-27 training plan. And we had quite a lot of talk about the a slightly different approach to the training, where sort of digital hubs have been set up for staff to access different parts of training that are most relevant to them. And that was quite exciting. The workforce risks continue to be effectively managed, and there were no new risks that required escalation to the board. So overall, we approved the 2025-26 people and OD effectiveness review of the committee itself. We approved the revised committee terms of reference, endorsed the medical workforce plan, and we supported continued delivery of Transforming People Services, the Employment Rights Act and the workforce strategy and training plans. So since that meeting, we've had a meeting a couple of weeks ago. The assurance report for that will go to the next board in August, I think. And that was to sign off the workforce disability standard, the equality standard and the workforce planning report for the coming year. So I think that's probably all the highlights, Caroline, unless there's anything people want to ask.
Thank you, Carrie. Are there any questions or comments to Carrie? No. Okay, thanks very much, Carrie. Go on to Phil.
Yeah, my assurance report relates to a meeting that we had on the 8th of April. And quality committee, we've got some new members, such as Andy, Carrie rather. When you first start working in quality committee, you're amazed by that you're ahead of a pyramid of massive amounts of data. But increasingly, we've been thinking about the so what, and for us, we've had an increased focus on patient-reported outcomes and making sure that the patients are involved in their care, and also trying to see where the quality of our care measures up with whatever comparators we can find, and they're more difficult actually than we thought, and so some national comparators are not always present. And if it's difficult to measure something, we're also looking at qualitative ways of measuring how patients feel about their care and what's important to them. Sort of three things just to mention from the meeting. Now that we've updated the board assurance framework templates, we're renewing our scrutiny on the areas that our committee focuses on. And the next meeting, we'll be looking at in detail enhancing prevention, wellbeing and recovery. Recently, we've had much more focus on CQC, both on mock CQC inspections and actual CQC inspections, such as Townend Court, which for information was good overall. And also we've started to look at the safer staffing report, and that's coming to quality committee before it goes to board. And there were lots of other detail, but I'll leave it there.
Thanks, Phil. Any questions to Phil? Isabel.
Yeah, thanks, Phil. It was just to pick up, and I've done it here because you've got a little report on it, on the neurodiversity waiting lists for children, because I know there's that work ongoing with the ICB to try and improve the pathway and maybe get some more funding. And there was a very brief update, but is there any progress on what's happening in that wider system work to tackle the waiting lists, please?
Michelle's going to answer that, I think.
Well, thanks.
Yeah, I think I alluded to Isabel in my report. Yes, we have made a lot of progress actually both on the outer areas and the neuro ADHD. So we're just doing the due diligence on the money and looking at, they have sent through some contract specifications and processes that they want to look at. So we're just going through the detail of those at the moment. But after I think all the constant feedback that we've been giving them, they have now given us some processes, and they are going to be transferring some of that money, if it's suitable terms for us, into the organisation.
Thanks, Michelle. That's great. Thank you.
Just from a quality committee, I'd say that it's one of those things that seems from the outside that it's not moving, but when you actually see the amount of activity at every level in the NHS that our executive team have been doing, to think now we start to make some movement is great, because it's been very frustrating and very difficult to make changes, even though our trust has been coming up with lots and lots of potential solutions to this big problem.
Yeah, no, thanks. That's great. And I think to get that little bit of extra detail around the bones of what's happening, because if you get the headlines, then there is stuff going on behind the scenes, but we can't acknowledge it if we don't know what's going on. Thanks very much for that, both of you. Thanks, that's great.
Thanks very much, Isabel, for that question. We'll move on then to Kath for your report.
Thanks very much, Chair. So the audit committee was held on the 18th of May, and I'll just sort of give you some highlights. So there was a number of positive assurances received from various internal audits on succession planning for the organisation, lone workers, clinical stock management, the medical examiner role, and the BAF and risk management processes. And indeed, we invited internal audit to come and present to our latest board strategic development day on the board assurance framework and some benchmarking work which they have done on what good looks like across the patch. So that was really interesting to receive that. As I mentioned when we were talking a bit earlier about the provider licence, at that point, the draft head of internal audit opinion was going to be issued as significant assurance, and we have had that finalised at a subsequent audit committee meeting and confirmed as once again significant assurance, which is a good outcome for Humber. The position with audit recommendations, we're still showing as positive, and we continue to chase down with the very able team that underneath P to keep an eye on all those audit recommendations to make sure they are closed in a timely manner, and we keep an eye on that evidence to support that. One of the things we also did at that meeting was sign off the counter-fraud plan for the coming year 26-27, which is based on a risk assessment which is on nationally mandated standards, and that's about how we'll spend our time in fraud prevention and detection as well as fraud investigation. So the audit committee signed off that. We have had a subsequent audit committee meeting which was held in June, which was all around the sign off of the year-end statements, and obviously that'll come to a future Council of Governors, and obviously you'll hear direct from the external auditors at some point later on this year when they present their letter back to the Council of Governors. But there's no issues to report at this point in time. Happy to take any questions.
Thanks, Kath. Isabel?
Sorry, it's an old hand.
Oh, okay. Any new hands? No? Okay, thanks, Kath. Steph?
Thanks, Caroline. Yeah, this is a report from the 7th of May meeting of the Mental Health Legislation Committee, where we discuss the usual reports that we receive in relation to Mental Health Act, use of force, etc., etc. Just a few things to highlight. Mental Health Act 2025, as it's styled. We're still in the very early stages of that. The project team has been established, but we will not really start making a great deal of progress until the Code of Practice is in place early next year, early 2027. So watch this space for that one. Continue focus on reducing restrictive interventions. Really excellent work there by the Trust in terms of our performance there. We're very much at the lower end nationally in terms of use of restrictive interventions, and our training compliance is really good. So excellent work. Continued work on missed seclusion reviews. We've got some really good data now within System 1, so we can see exactly what's happened and monitoring it. So really good work there. We're looking at benchmarking, and again, it's something that has been alluded to already by Phil in terms of the lack of comparative data nationally on some of the things that we'd really like to monitor. We're trying to make some headway on that and look at what we can pull together to see to compare ourselves with other trusts. Hopefully that will continue to develop over the next year or so, but it's a little bit frustrating for us. And I just wanted to highlight work that's been done in the Trust in relation to responding to national work by CQC on Monitoring Mental Health Act in 2024-25, including inequalities. So there's work being done there. A couple of specific pieces of work that we've done in the committee, looking at gaining assurance around risk assessment prior to patient leave, which we've received assurances around, and Section 132 rights and appeals against detention under Mental Health Act, where we've had a really good detailed look there about whether patients are getting their rights in a timely manner. I'll leave it there. Thank you.
Thanks very much, Steph. Any questions to Steph? No? Okay. Thanks very much to all those NEDs for their chairs reports. We'll move on to item number 10, trust compliance with fit and proper person test. I'm looking at time. Basically, we have filled in all the requirements and submitted our declaration, and the outcomes were shared with the ATC. So I'm going to go straight to any questions. No, that paper's for noting. Thank you very much. We move on to item number 11, the annual effectiveness review of the Council of Governors, including terms of reference. Again, on this one, just to say 19 governors and 6 board staff members completed the returns. We had a really good session at a governor's briefing. I hope people would agree who attended on the 30th of April to review some of the results and outcomes. I think overall it was a really good response with some areas for some reflection on as well. And I think one of the aspects for me to take away was to encourage and support more governors to participate at these meetings. So I will give governors priority when it comes to asking questions, and will seek governors who want to. And if any governors want any support or understanding when they've looked at the papers, or anything in terms of the sort of questions that are appropriate for governors, please contact Stella. She is there to give some support in that area. I'll take the report as read. Other governors happy? Any other questions or comments on that report, item number 12? No. Okay, is happy to approve, I think, that report actually. Yeah. Okay, thank you very much. Well, then we'll move on to item number 12. The effectiveness review. Marilyn, it's you for the Appointments, Terms and Conditions Committee. Marilyn? Okay, I'm telling you what, Marilyn? No, okay. I'll come back to that one. Let's go on to
I'm here. It's just
brilliant.
I've had to switch my camera off because you all went away somewhere. I don't know where you went, but you did. Yeah, I mean, I think we've been quite busy doing the things that we do. Obviously, I've been involved in the interviewing of the appraisal interviews and so on, and I think they all went very well. Though we've reported back to the committee yesterday. It seems like, yeah. And we've looked at our terms of reference, and we haven't changed anything on there because we didn't need to. So we approved that. And we noted that the Engaging Members Group review has been analysed and is going to be discussed at the next meeting, which will be shared with the Council of Governors. So I think that's all I've got to give you at the moment.
Okay.
Yeah.
Thanks, Tony. Did you want to add anything as chair of Engaging with Members Group?
We haven't had a meeting recently, so we need to think about what we're going to do with that. I think this links a discussion we're going to have in part 2 as well.
Okay.
So I'll just leave it there. Thank you.
Yeah.
Thank you. Any questions to Tony or Marilyn on that? No, thank you. That is for noting. We'll move then on to item number 13. And I mean, we've got feedback from Appointments, Terms and Conditions Committee, the 21st of May 2026 report. Marilyn.
I've lost it.
It's item.
Oh, right.
number,
Yes. No, it's
yeah.
fine.
Cool.
So many papers. Yeah. I mean, we did have the annual effectiveness review for the committee performance, and no changes were made to the terms of reference, which I've already said. The annual review, effectiveness review has been forwarded to the Council of Governors for assurance purposes. And the Appointments, Terms and Conditions section of the annual report was received, and the committee members agreed this was an accurate reflection of the work undertaken. So, as I say, we've been quite busy, but nothing that is not out of the ordinary, really.
Thanks very much, Marilyn. Any questions to Marilyn? Comments? Okay, thanks very much, Marilyn. We'll move on then to item number 14 and the place report. Pete.
Thanks, Caroline. I'll try and be brief because I'm conscious of time and I know you've got a part 2 coming up. So this paper presents the 2025 place results, which we have seen at Capital Group, EMT and board. You know, I'd like to thank the governors who participated in the process this year. It's the first time governors have been involved since the pandemic, and I think, you know, their input and support was valued by the place team. You know, very quickly at aggregate level, we have made some good progress on our place assessments. The number of exceptions where place identifies something we need to remediate has reduced from 382 last year to 162 in the current round, and we monitor progress against those 162 through the health and safety group with escalation as appropriate. You know, I will say very quickly, we don't rest in our laurels. There's still work to do, but we do set capital resource aside in our capital programme for place and statutory compliance to help with some of the works that have been identified. And I will stop there and go to questions, Caroline.
Thanks very much, Tim.
Well, it's to do with the appendix, and you've lumped Millview together as one, but in fact, of course, Millview is two separate units catering for two totally different client group. One is Millview Lodge and one is Millview Court, one for the elderly, one just generally for mental health. And I just wonder whether you should be separating them out in future, because I would have thought that one of them might bring down the score of the other unfairly, because when you look at all the other ones in the appendix, they're all individual units. And I just wonder for the future whether you ought to split them as the two separate ones. You have got, after all, you haven't got Maester Lodge and Court because they're both the same patient group. This is the only one which has a totally different patient group. And it may be that the services and the facilities and the standard of decor and everything are quite different between the two. And I just make a suggestion that maybe that's dealt with for the future.
Thanks for that, Tim. Pete?
It is something we can look at, Caroline. I don't know whether we're mandated by the national spine on what we can and can't submit, because obviously the other one, Tim, would be Miranda House, which has Avondale and Peaky,
Oh, yes.
two separate wards, but we do that as one. And I don't know whether we're constrained by the national collection, but it's something I will ask, Tim. I'll take
Yeah,
away
thanks a lot. Just a thought.
That's a
Thank
good
you.
Yeah, I
observation.
think no, it's a really helpful suggestion, and we might not be able to do it for the national collection, but there might be things that reflect a difference, if you like, that you'd want that to the people who may be doing better or whatever.
I'd
to
forgotten about
not
Miranda
be
House
lost.
as well. I forgot
Yeah,
about
Miranda-
Miranda House as well, because Pico obviously is very, very different from Avondale.
Yeah. And Kwame and I were up there just the other week, weren't we, Kwame, doing an unannounced visit to both those units on that particular site as well. Okay, thank you. And could I just flag, we will be looking for governors to take part in the next set of place assessments. Don't need to go into it now, Pete, but it'd be great to get just a bit of follow-up of, I know it's, obviously we don't tell the places when we're going there, but it'd be really good to have some sort of window, and so we could get some availability from governors for some of those visits. Julian Barnard did a tremendous job last year. I think he topped the polls in terms of governors who gave their time to attend these assessments. But it'd be great if we could just get that underway as soon as possible, but because it'll be hitting us soon, won't it, Pete?
Yeah, it's late, it's usually October, November time from memory, Caroline, but we do pre-plan the dates. So once I've got those dates, I'll get them circulated around governors to look for volunteers, if that's okay.
That'll be great, as long as governors keep the dates to themselves within the circle of trust. Thank you very much. Okay, brilliant. Katie?
Hi, Caroline. We do have the dates, but we just don't have the venues at the moment.
Okay, well, why don't we get the dates? Well, let's do it offline. We'll sort that out. I think we just need to get the time in for governors, which would be great. And then, it's going to be a potluck where they might end up on those dates. I think we could do that. Okay.
Thank you. Brilliant.
Great. Thank you, Pete. Let's move on then to the next item 15, performance report.
Thanks, Caroline. I'm mindful of the conversation earlier, but the link to the most recent performance report is in the body of the papers. And most governors will notice that we've kind of refreshed the board performance report ever so slightly, which we do every year. We review it every year to see how we can strengthen it. And this year we've strengthened the commentary by grouping the indicators to the most appropriate group or committee that have oversight of them. And then we've used a way to make it more integrated and strengthened rather than just a front sheet. We've almost got a pseudo front sheet for each of those grouped indicators. I've included in the body of the report just a quick update on where we are on the national oversight framework. So we retained segment 1 for Q4 and actually climbed up to 4th in the country. So I think that's really positive performance. And we saw from Matthew earlier some of the community indicators we performed really strong on. I'm going to take the rest of the report as read, Caroline, because we've got 10 minutes of the meeting left and I've still got my finance report, and I'm happy to go straight to questions.
Thanks very much, Pete. Are there any questions for Pete? Over to you, Isabel.
Yeah, just a really quick thing, Pete, for my understanding. Can you explain what full meaningful help clock stop is? Because I noticed that for the first time. Maybe somebody else will be answering that.
I have got that definition, just not to hand us, but can I circulate that outside the meeting?
Yeah.
Because it was asked and it was in the board paper, but I will circulate something as a post-meeting note if that's okay.
Thanks.
Yeah, that'd be helpful. Thanks, Isabel. Any other questions? Okay, let's move on to finance.
Yeah, so again, finance report this time covers both 25-26 and 26-27 financial years. So very quickly, very pleasingly, and we picked some of it up in CAF's audit and Keith's finance. We delivered our forecast for the 25-26 financial year, which was the 3 million surplus, which we have been forecasting since probably the autumn time. You know, that in-year forecast was due to technical accounting treatment of non-recurrent income, and it does convert to capital cover in future years for the trust. So there is a benefit to declaring the surplus, and it will help our capital ambitions. For 26-27, we submitted a break-even plan. Our plan was deemed as compliant by NHSE. I think we may have reported that to governors previously, but we remain the only organisation in Humber and North Yorkshire with a plan that has been deemed compliant. And at month 1, we recorded a position consistent with plan. Cash position remains stable at 24 million in the bank at end of May, and we are continuing to see good performance in our better payment practice code. So we're not managing the cash by slowing down the payment of our creditors. And I will stop there, Caroline, and I'm happy to take a question.
Thanks very much, Pete. Tim?
Sorry, me again. I'm going to write to Pete on 1 or 2 things because we haven't got time. But I don't know where that noise is. But I'm concerned that we only got figures up to the end of March, and here we are now, middle of, in fact, just middle of July. There's nothing at all yet. I know we haven't, I suppose, finished Q1. Is that the reason why?
Pete?
We haven't got figures from the Q1. Anyway.
Yeah, sorry, Tim. I was on mute then when I was talking. First time today, by the way. So, in terms of the report, we have got the figures to the end of April, which is the latest position that's been reported to the board. So it isn't a table, it is just a confirmation that we recorded a break-even position at the end of April because it was a light touch month with NHSE, but we have shown cash and better payment practice code. The table is only to March because that was me showing 25-26 year end, and I've tried to split it to try and be helpful for governors.
Yeah. And can I just say congratulations for all the hard work that's been done to achieve what you achieved in the last financial year.
Thank you. I'll pass it on to everybody because it's a team effort. It's not just finance, it's the whole organisation.
Yeah, fine.
Yeah, and you know, it's not without its challenges. You know, sometimes I think it can be assumed that, you know, some other trusts, you know, are having more difficulties. It must be easy for Humber. It's not. It's a challenge for us as well. But you know, our financial controls that we have are excellent, but also our ability to forward plan services and give that sort of confidence to services when they all are asked to go through the budget round, Pete, and submit what they want for the next year, to be able to actually give them a definitive sense of what that will be and give that stability both for our staff and for our patients and developing services, I think is just really, really amazing, quite frankly, in this climate. Okay, any other questions? Brilliant. Okay, thank you very much, Pete. Thank you to everybody who's presented and for your reports today, and thank you to everybody for your questions and comments too. I haven't received any other business. Are there any comments people would like? We have had some comments about the board papers at the top end of the meeting. So, you know, obviously some feedback was given to Tony and others about that, but I will go away and have a look at some of that as well. And there's a few things about, you know, maybe supporting governors with how to use the sort of the pack to get through it quickly and use some of the tricks that Isabel mentioned to do that as well. Are there any other comments from governors about the content of the agenda and so forth? Marilyn?
Can I just say, regarding to the subject of papers, when we've those of us who have only one computer, I don't have two, it's very difficult for us to go. I mean, we go through the papers beforehand, but it's very difficult for us to track things because we have to switch off the main bit to get. And so that's why I personally feel that getting the papers, and I understand what Michelle's saying, and I bring my papers back for them to be shredded. But I just think it's not easy when you're a lay person to actually keep in touch with all the things without having two screens.
Yeah, I appreciate that. And you can split the screen, but if you've got a small laptop, it isn't easy. I'm using 2 laptops at the moment today, so I'm doing it all paperless today. But I've got 2 laptops working.
Yeah, well, I've
so
only got a
I hear that.
laptop. Yeah.
Thank you for that. Any other comments on the meeting and the debate? And I hope everyone felt they had a chance to contribute, or if questions were asked by others, that it was whatever you had in your head was being maybe asked for by someone else. Any other comments on that? Yeah, I think the meeting has been conducted in a really, given the heat and everything else that's going on, in a really good manner, in line with how we'd like to run meetings. Appreciative comments, challenging questions, and listening, which is really always really important as well. So thank you very much. We are, in fact, 5 minutes early. So we'll rejoin at 11:40 for part 2. So that gives you an extra 5 minutes to have a bit of a break before we start the next meeting, which we've only got 1 item to discuss. So I'll see you at 11:40. Thank you very much, everybody.
Thanks, everybody.